Good afternoon, everyone. There's a few names listed in the chat, and I believe a few of you sitting in seminar rooms joining in. Zoe asked me to give a bit of a talk about some human factors, and it left it to me to choose how I put them into an application to discuss today. So I thought that what I'd like to focus on today is the human factors in the working environment and how that relates to patient safety incidents and how we might mitigate the risks associated with that. So what I had planned was that the speech bubble makes an appearance along the way, at which point I'm looking for your input. So this might just be Gary, Heather, Zoe and Matt joining in with conversations. But please do type in the chat if you're able, or those of you within the seminar rooms, put a virtual hand up and join in the conversation if you'd like to participate. So most of you might have heard, if you know me, that as a New Zealander, I'm doing what all New Zealanders do eventually and returning home. So my first question, just to warm up this interaction, is what's the worst thing about moving? While you're thinking of some answers, and I've got the chat listed up and beside me to keep an eye on that. When my parents decided to downsize, my mother specified that they could not move further than a certain distance from their local supermarket because she decided she was too old to learn the layout of a new shop. So I guess in many ways, the worst thing about moving depends on the context. And certainly if you're an anaesthetist, the worst thing about moving is, of course, getting used to a whole lot of new monitors and an environment where things may go beep that you don't recognise. And that state of constant vigilance that we all live in when we're in at work can actually become quite stressful, trying to work out what's making a noise and what you need to be paying attention to. Not knowing who to talk to and to get stuff done and ask for help is Zoe's contribution to the chat. Absolutely agree. And that is something else that I'm kind of, I'm worrying a bit about, but actually in another respect, seeing as I tend to be the person everyone comes and asks where I work at the moment, it's going to be quite nice trying to find somebody else. So what I wanted to sort of start talking about is a slide that I've shown in previous talks, and that is just reviewing one element of human factors, and that is people and their non-technical skills. So contributions please in the chat. What do we mean when we talk about non-technical skills? What are those skills separate to performing an ECMO cannulation or putting in a urinary catheter? Oh, the other thing about the yellow speech bubbles, I don't move on from these slides until someone, at least one person, has put something in the chat. Talking to people, thank you. Leading.
There's something quite poetic about saying talking to people and actually typing it into a box rather than
I know
using
it's
your
nuts,
mouth,
isn't it? I really this does not play to how I like chatting about this stuff. It's and it'll kind of come up again a bit further on. But you're absolutely right, Matt. It's non-technical skills in a technical age. Okay, so I've got a couple of things. I'll move on and just remind you all of the non-technical skills, which can sort of be summarised. Situation awareness, so that is what, so what, now what, you know, and assessment and anticipation of what's coming next based on your observation and interpretation. Teamwork is all about your staffing and your skill mix. Communication is about language. We use a lot of social language in our working environment. Other safety critical industries would be appalled at the way in which we chat about stuff. Bit of bleeding, slightly tricky airway, you know, for someone with no chin. Leadership. Who's in charge? Is it the same person for the whole day or throughout the entire case? How do we decide who's a leader and how have they learned leadership skills? Decision making is about the obvious thing. What are we going to do? How are we going to do it? And then finally, task management, organisation of the team, deployment of the team to complete the task, but also reviewing that task as you go along. What are some other characteristics of humans? What else makes us people and slightly different from the monkeys?
Maybe showy.
Sorry, what was that about?
Showy. Showy.
Showy.
Yeah.
Showy?
Trying to show up.
I think show off. I think is what the.
Ah, okay. Yeah, we like to show off.
Yeah.
Okay, that's my one. You're a really tough audience today. So there's a variety of things, aren't there? You know, we've got personality. We can't really change that, but we can choose behavior. Our feelings and reactions. Feelings probably emerge despite ourselves. Sometimes we can control those reactions. Pride might be what you're talking about people being a bit showing off how slick they are at doing something.
Yeah, second language.
That's it. Shame is another very human emotion, although I believe monkeys have been shown to demonstrate this as well. Embarrassment at doing something foolish or incorrect. And then, of course, we've got the halt combo on the right-hand side there, hungry, angry, late and tired. Stuff that we know that as humans will all impair our performance, which may lead to pride coming before a fall. The really important thing about humans that we all need to understand about ourselves is that we are absolutely hardwired to take shortcuts. So, you know, this well-worn path, you know, someone's actually mown the lawn here, but the hard-worn path has obviously been used by many people to reduce the distance that corner represents. What non-technical skills are we seeing applied here?
It's a very short space to say time management. What can be time management?
Yeah, but we're all about productivity. Every tiny little take 3 less steps.
Yeah.
Hard to see how that really does save any time. But the point being that we're so hardwired, we don't apply the logic, we just take a shortcut. Some town planners actually let people walk on the grass and then build the path where the people go.
Yeah.
So if we're thinking about, I mean, I am taking the piss slightly here, but to coin a Kiwi phrase, I've got to get my accent built back up again so they don't think I'm English when I get there. Situation awareness. Someone has assessed this situation and noticed that there was a quicker way to do something. What was the significance of cutting that pathway? Others have clearly worn this path before and there's no evidence of adverse consequences. So it's obviously safe to keep taking this shortcut because nothing's gone wrong. There's no sign, but somehow we've communicated with each other that it's a safe easy thing to do to take this shortcut. Someone did it first, they must be the leader. Someone's risk assessed this as safer. They're avoiding the traffic on the actual pathway. And also it's dry, so the shoes aren't getting muddy, and as you say, Abbas, they've saved some time. Does any of that sound familiar about shortcuts that we take in the workplace on a day-to-day basis? Yeah. Here's someone else taking some shortcuts. He's never fallen off his bike, so it's never been a problem. Here he is 3 months later. He's never fallen off his bike. It's never been a problem. That we are doing something unsafe and it hasn't gone wrong reinforces that we've made the right decision to do something in a way that's cutting corners. In fact, it's so much that we, in our workplace, I think quite often feel this kind of irritation about things, and by this I mean checklists, just in case. I hope Dan O'Neill isn't on the call because he'll start shouting. But we get irritated by checklists, don't we? That, well, of course I'm going to be safe in this environment. I'm not going to do anything stupid. And yet we've just established that actually we're human, so we're going to take a shortcut if there is a shortcut to take. I think the number of electronic pieces of equipment in our operating theatres has expanded exponentially since our operating theatres were built, except in orthopaedics at the General. This is a picture of the floor in the emergency theatre, where things might get interesting and you've got to move stuff around quickly. We accept this as normal. The standard you walk past is the standard you accept, which is why if I'm ever in there, we get the trip stop out to make it a bit safer, but also because anticipating that you've got to move things around quickly and get more instruments in when you've got that tangle on the floor, never mind the trip hazard. So enough about cables on the floor. What other human factors contribute to our working environment? And by that I mean, I don't mean they're not non-technical skills. This is something that I think a lot of our management team confuse. Human factors aren't just non-technical skills, there's other things as well. So ideas, please, as to what those other things might be.
Where you put equipment?
Equipment, yep.
Noise.
Noise, yep. Noise in the operating theatre, including music, reduces performance by up to 10%.
Have you told Mr. Nakas that?
Especially yesterday when Mr. Best was playing AC/DC.
Oh my God.
Back home problems.
Say that again, Abbas.
If someone comes with having problem at home, actually, before coming.
Yeah, okay, so those are sort of external emotional issues.
Yep.
Probably still fits in that non-technical skill stuff. But yeah, if everybody in the team's bringing that in, that's definitely having an impact on the day as well, isn't it? So Zoe mentioned equipment, thinking a bit more about that and how you organise the equipment in your room. What other ideas might come up about that? Anyone heard of the term ergonomics? What does the surgeon usually say at the beginning of an operation? Table up, please. At which point, if you've seen the Dr. Glockenflecken videos on Twitter, you make a buzzy noise, but don't actually lift the table. Look it up, it's hilarious. So when we talk about these non-technical skills, in fact, this is just a really tiny part of all the other human factors, the interaction between humans and the technology, processes and systems required in their working environment. So the design of the equipment, where you put it in the room. How annoying is it that we've got anaesthetic machines that have fresh gas flow that comes out of the left-hand side of the machine, and then because the pipes are all on the left-hand side of the operating table, we've got tubing crossing across the space in which we're trying to work, and that shortens the length of the tubing that we've safely got between the machine and the patient. Have a look at that next time you're in there. Look at the setup of your room. It all makes a difference to how your workflow operates as well. So I'm not going to dwell on every single one of these, but what I do want to do is kind of get you to think about how these factors might start to influence our working environment as we go along, and discuss a couple of incidents in a minute. So if we're talking about patient safety incidents, I'm presuming everybody on this call has at some point filled out a DATIX. And that associated with this is some grade of harm. Those will be no harm, near miss, minor, moderate, serious, and death, which is clearly a subset of serious. So there are 10,000 patients in the NHS every year who experience serious harm and/or death. And there's about 400 a year that have a never event. So we'll move swiftly on from that, but you can draw your own conclusions of what I think about where we need to focus our patient safety agenda. So PSI, patient safety incident, serious untoward incident usually means moderate or above. And all of these incidents within our patient safety team will be investigated usually with a root cause analysis. So anyone know what any of these investigative tools are? Statements and timeline are a given. 5 whys, who's got toddlers? You'll know what 5 whys are. Come on, Matt. I can see you thinking.
Sorry, I thought you said 50,000 whys, not 5.
It's the idea of getting to the point that you exhaust all possible answers, and in a grown-up's world that usually takes about five whys. I know in the world of small children that doesn't ever get satisfied.
It's comparable to sort of so what, isn't it?
Yeah.
So the so what question, but the other way around. Yeah.
So a change analysis grid. Anyone know what that is? So I've got an example in a minute. This is where you are effectively writing out work as imagined. So what should happen if you're following all the policies, guidelines, best practice and all the rest of it. And then look at why that didn't happen. And what you needed to change to get the safety steps in place that would have avoided the incident occurring. And then fishbone, everyone heard of one of those?
You made me do one.
What's that?
You made me do one.
And it's made you the man you are today, Matt. So this is a pretty typical kind of layout of a fishbone. It's basically a checklist for incident investigation. And as you can see, there's a hell of a lot of things there. We talk about a root cause analysis investigation like there's only one thing that's ultimately been the absolute reason something happened. But more realistically, there are often several equivalently significant issues that are cropping up and contributing to an incident. So I thought we might just have a bit of a discussion and/or root canal work to see if we can actually talk about some of these boxes here. In a hypothetical way about what about a patient might mean that they're more likely to have a patient safety incident. And I'll give you the first one for free in the patient safety box, and is actually comorbidities. If you're a diabetic, you are far more likely to experience a patient safety incident while you're in hospital with other people who don't know what they're doing looking after your insulin. Unconscious and unable to self-advocate. Thank you, Fran. Also unable to move, hence pressure sores. Anything else about patients? Patient you don't like, patient with difficult relatives. Yep, because we are human too. And sometimes it can be really difficult parking how you feel about some patients. Zoe.
I was going to say patients who actually know stuff, who might be doctors or nurses or whatever, get treated slightly differently, but Jenny's just written it as well. Yeah,
and not always to their advantage. You know, there's that joke about, which is not really a joke at all, that, you know, the birthing plan of any medical person is not going to go according to plan, you know, and it's important that we really do treat people the same, including Novak Djokovic. Okay, how about the next box over? I've just can't, it's so small on my computer, I can't read what it says. All right, individual staff factors. What kinds of things are going to put in there? I think, Abbas, you mentioned one earlier. Coming to work with a whole lot of emotion. If you've just had a big fight at home with with your partner, or you've found yourself stuck in a traffic jam, so you're running late.
Yeah. Undertrained, lack of self-confidence.
So your feelings about your own abilities, how you've been made to feel working, you see that, oh my God, I've got to work with Dr. Charlton tomorrow, not sure how I'm going to manage that. So those sort of psychological factors and our personality and how we cope with stress is also going to influence how we behave in a given situation, and that may actually influence the outcome in an emergent event. How about task factors? Is it something you've done before? Sorry. Is it something that you're familiar with? Are you familiar with the task but not the equipment that's suddenly been changed because it's all run out and now we've got something that looks completely different to what you've used before? Any other ideas around tasks? What makes sure we all do the same thing when we're putting in a central line? How do we decide how we're going to go about checklist? Yes. Training. Standard operating procedures. So guidelines and protocols are really important in trying to eliminate variation and therefore the emergence of risky activity surrounding a particular task that may be associated with significant complications. Okay, so communication factors. So are you trying to do something with a group of people talking down a blank screen in a room on your own, having to wiggle every now and then so the lights here don't go out, but don't feel sad for me? PPE, getting in the way of everything, absolutely. What else about communication? We're a wonderful multinational organization, aren't we? And if someone's got a mask on and someone like me is starting to lose their hearing, that's part of the PPE problem, but also all of us have got accents of one sort or another. So that can add to confusion and confidence as well in how loudly we speak, particularly in a challenged environment. And also, as I mentioned earlier, the language we're using, professional versus social. And I think sometimes it's really important to speak like you've been to medical school. You know, the modern thing is that we need to dumb down complex medical language, so that dumb down's the wrong word. Let me rephrase, make it non-technical, so that when we're speaking with relatives and patients, they can understand what we're talking about. But sometimes we forget to just upskill that a bit when we're communicating with each other and actually be clear about what's going on. Team factors. What kinds of ideas come to mind that might compromise the smooth running of a team?
Difficult hierarchy.
Yeah.
Whether that's people are afraid to speak up, or whether that's actually too many people at the same level, so nobody's in charge. Like if you have three or four anaesthetic consultants doing the same job, nothing actually gets done.
No, absolutely. Very, very dangerous. If you've got that many people giving one anaesthetic together, it can be difficult. Missing key members of the team, absolutely. So we quite often see people trying to get started with the team brief early in the morning in theatres, when actually the scrub nurse isn't there, or the ODP, because they're busy still getting stuff ready and essential equipment isn't available, and that's quite important information to have with everyone there. So the team is everyone. And it's really important that we emphasise that to all our colleagues when we're working either at a safety briefing on ICU or in theatres. Education and training factors. Lots of trainees here. What do you feel, if you've been involved in a situation that's made you feel anxious that something might go wrong? Was there education and training that might have made a difference? Or was your education and training what saved or salvaged the situation you found yourself in? You're muted, Abbas.
COVID, lack of theatres makes, again, problems in the training. I can also say sometimes it's like asking how can I say it, not asking for learning in the proper timing also would affect our understanding of what's happening, not reflecting on our practice. What else?
So education and training, it's about not just the trainee working out what they think they need, but supervision, making sure that competencies are appropriately assessed, that there is understanding, not just, yeah, I'll be fine because you've asked me to be. You know, are you happy is the most dangerous phrase a consultant can ever utter, just about, because the confirmation bias will be, you'll say, yeah, I'm happy. That may or may not relate to the task that you're being left with. The accessibility of training, we run things, but not always at a time where people are able to get to it. And I guess that's one tiny advantage of the online format, is that actually we can run sessions in a way that not everyone's got to drive across town to spend an hour driving around a car park. At least this way you can listen in the comfort of your own home. But it does reduce...
the tech works anyway.
Once the tech works, but it also reduces the educational value to some degree, in that interaction is just that much more difficult. So working conditions, equipment and resources, seeing as we mentioned IT, but your working conditions, have you got what you need to complete the tasks you're being asked to do? And have you been provided with the resources so that once you've completed difficult tasks, you have a bit of downtime and an opportunity for rest during a long and busy shift? Equipment and resources is sort of what it says on the tin, really, doesn't it? Has the equipment been designed appropriately? Has the environment been designed appropriately? And what are the the usability, that interface between technology and the human using it, has the pump been designed so that you can program it without having to read a 20-page book? And then finally, organizational and strategic factors. So this is really about culture. And if we move on to the next slide, where I've sort of filled all the boxes in, I think the organisational and strategic factors are one of the most important elements of all of this. It sets the tone for the environment in which we work, and as employees gives us the confidence to know that if we feel unsafe or uncomfortable or uncertain, we are actively encouraged to speak up and be heard, and know that there's no penalty for asking a question because you're uncertain. And I think everyone, you know, I would hope all the consultants that are part of this call would absolutely agree that that's part of our job, is to create that environment, even if sometimes the organisational pressures mean that it's difficult to do so. Part of our job as leaders within the clinical environment is to set those standards of safety and behaviour, and to support you when you find that difficult to deal with. Anyone got any comments to add to that? No? Zoe?
Not really, we just agree that that's a big part of what we do.
Yeah, yeah.
Always make sure everybody's happy before I leave when I'm on call. Not that I've been on call for a long time, but you know what I mean.
Yeah, well, I think the other thing too is that it's about making sure that people know that we have an expectation that we're part and parcel of troubleshooting whatever's going on. You know, the importance of support and team working does include the leader being involved, not just
people knowing that we can be contacted, whatever time it is.
Yeah, absolutely. So moving on from this a little bit, I just want you to think about this sort of collection of ideas while we're just working through two pretty simple intensive care type patient safety incidents. Some of you, apologies if you've heard me speak of these before, but I think they highlight the really important issues of working conditions and environment quite well. So have a think. These are the headings. First story is a very typical one. Happily no harm to the patient. An ICU transferred to radiology out of hours. Hands up who's done more of these in their life than they ever need to do again. Yeah, okay. This will make you all laugh though. It's a bit like obstetric epidurals, which I'm going to have to start doing again when I move to a Fonterey. Oh dear. Anyway, okay, so this is a junior doctor. It is September, new to the department, down to CT scanner, donut of death, accompanied by a member of the nursing team, and they found themselves being asked to do something unfamiliar by the radiology registrar, who was pretty insistent and quite strident in the way an instruction was given rather than a request, to hook up the IV contrast injector. In amidst the flurry of being in the CT scanner and the tubing and all the rest of the spaghetti, the high pressure line was actually connected to the arterial line and injected. So the root cause was that it was possible to connect the IV to the arterial line and inject. But there were lots of other things going on here, weren't there? So let's just have a bit of a think about what some of those things might be. So feel free to just type down the side, or if you want any clarification about the story, just ask. If you were doing this in a detailed way, you'd work through each of the boxes. So patient factors, the patient had an arterial line. They needed a CT scan with IV contrast. If neither of those things happened, then this incident wouldn't have occurred. Abbas, did you want to add something?
I just wait. Are you ready? You want us to say things or not?
Yeah, absolutely.
Yeah,
I'm filling the silence, but
yeah, exactly.
I'm very happy.
So education and training, for example, he hadn't get the proper training for how things are done in the hospital. It's his first day. Regarding patient human factors, it's a team factor. I can say the bad communication with the from the radiology side. Maybe also his individual factor that he couldn't resist and say no and yes, knowing the guidelines. He wasn't confident to respond to that. Other factors was going through the night, so his night shift might be tiring, might be have anything else that was concern to him. Lack of supervision, it's again overnight, so again this put more stress on him, and it can go also with work conditions. Equipment and resources, he might be not familiar, we say, with the arterial line. It might be lower lock or something like that should be done on the arterial line, so that to be inadvertent injection on it, maybe. That's what I can think of.
Yeah. Heather, have you got something to add?
No, I think that pretty much covered most of the things I was thinking as well, so not got really much else to say on top of that. Yeah,
I think a really important point mentioned by Chung, unwell patient by their nature, intubated, ventilated on intensive care and going for a CT scan because something's deteriorated, something's changed. There's lots of distractions. All your infusion pumps, all your monitors. If you're new, those might be monitors you're not familiar with either. The routine, the setup in radiology. But one question I would ask everyone, how many of you have ever connected up the IV contrast? Are you familiar with using that device? And we're quite, it's a bit like medics generally, I think, we're quite used to doing stuff. And if someone asks us to, particularly as intensivists and anaesthetists, we do practical procedures all the time. So, and lots of them, you know, you use a lot of pumps that no one's ever shown you how to use, but you kind of work it out. So we have that problem-solving attitude that sometimes means, not done it before, I'll have a go. And that's not always the right thing to do, to be helpful when you don't really know what you're doing. So that old maxim of see one, do one, perhaps might have helped here. But I think there were a couple of overriding themes in this incident that I'd just like to draw out a little bit. First one is environment. And a bit like moving, you know, when you're trying to cook in somebody else's house is really stressful. You don't know where the pots and pans are. You don't know where the spices are. And it's similar, being in this environment that is not of our own. We are not in charge of the environment. We're visitors. So, you know, do I take my shoes off at the front door? Which chair can I sit in? All that kind of stuff. Added in the extra hazard of having to be remote from your patient and trying not to get fried, or if it's the MRI scanner, that's just a whole nother layer, isn't it? So what other environments are you transferring patients to or from, and what challenges do you encounter in those environments?
I have to go to theatre.
Mm.
And then you get different priorities of different people.
Yeah.
And different familiarities. I think people in theatre might not be familiar with the stuff that's on the bed from the unit and vice versa.
Yeah. And that can be quite distracting at a point where you really want to be paying attention because you've just left where you were in a place of safety. Ambulances, confined space, lack of staff, equipment, and a moving vehicle. Absolutely. Transfer trolley, suddenly very narrow or doesn't fit in the ambulance. That's bad to find out when you're there. Knowing the best route around the hospital. Thank you, Catherine. That's a good point, because a little bit like yesterday going to work, I got stuck in a traffic jam because 2 articulated lorries heading to the new tent at Leicester General Hospital went round the back by mistake and got stuck at the right angle piece of road by the education centre. And we had a traffic jam, and that can be quite awkward if you're similarly transporting an unstable patient around the place.
Anyone got MRI is a pain as well with an ITU patient, because you have to change all of the kit and monitoring and stuff. You can miss things and it doesn't work very well.
And from personal experience, when I had longer hair, you have to remember to take your hair clips out as well. I could feel myself being pulled in. Fortunately, not scalped. It was a cheap hair clip, but you know, it was quite a strong pull though.
Interventional radiology can be a real issue as well, because you don't know whether you're going to be there for 30 minutes or 3 hours, and you can't get anywhere near your patient for most of it.
Yeah, so there's lots of challenges there. What can we do to mitigate some of those?
Don't leave.
Don't do intensive care. Yeah. Just say no. Get someone else to do it.
Get half of your limbs replaced by metal, never have to go to MRI ever again. That seems to be a good plan.
Well done, Zoe. You need never worry about having to feed infusion pumps through the wall again.
Do a transfer training.
Transfer training. Yeah. Only work for a hospital with a transfer team. Yeah.
Checklist.
Yeah. Yeah, they do actually serve a purpose, don't they? And particularly when you've got so many distractions. So let's just move on. So that was thinking about environment. Let's think about some equipment design. Needle-free non-injectable arterial connector, genius. Not using this device would seem like folly. That is a comment from a patient partner who was asked about the idea. And this is a picture of what can happen if the wrong thing gets squirted down your arterial line. So, seems like a great idea. I can't actually find this product on NHS supply chain. And I don't know if anyone on the call actually has it in their unit. Anyone seen it, used it? So you can aspirate, you can take samples, but you can't inject. Lower rates of infection. Why wouldn't you? When it was introduced as an innovation award, it cost £2 versus 40,000 if you get patient harm from injecting. Interesting idea. Any thoughts? Because actually this is the ultimate way that you create a barrier to an adverse event. If you can't inject down something, you can't inject the wrong thing down it. So anyone got any other examples of good or bad design that they can think of in a working environment? Jenny, hi.
Hello, can you hear me?
Quietly.
Okay, is that better?
Yeah.
Okay, brilliant. So we've had a situation with the water supply in the hospital. The idea was we should put tap filters on so that the water coming out was okay to drink, which was fine, except there was one tap that it didn't fit on, which was okay because most people knew about it except one of our speech and language team who didn't, who of course takes water from that tap and uses it to assess patients' ability to swallow safely.
Eek.
So, you know, people said, well, there should be a sign, but actually it's far better if you put a filter on every single tap, because then it's impossible to do the wrong thing.
Yep, absolutely. Absolutely.
If you take it out of the equation and put an engineering solution in, it makes it much safer.
Yeah.
Also, if you go back to the beginning of COVID, thinking about improving ventilation in hospitals, it then makes less of a difference if people put the wrong thing on or take the wrong patient to the wrong place.
Yeah.
So engineering controls are very important.
Yeah, absolutely. So here's a little question for you. This is a gas monitor. Is it on or off?
The eternal question. No one can ever work it out.
It's on, I think.
No,
It's
not.
off.
Oh.
The lights are off when it's on.
It's on standby.
Oh, okay.
So that's
no,
why
yeah, both lights are off, yeah.
At the general, both lights have to be off to mean that it's on, because there's a tiny little green light down on the right hand side by the on off button. That's what tells you that the machine is on. The green light says it's on standby. We wrote to Philips asking him why the green light didn't come on when the machine was activated, the gas analyzer was activated, and they said that was silly, no one would think that. So obviously someone manufactured the wrong colour into the button and they're just covering up. In the chat here, some other ideas. Yes, there is a magnetic lockbox for suturing for the CVC that can only be released by the guide wire being threaded into it. Now, I would imagine that's a two-handed task. And if you've got an awake patient in an emergent sort of situation, I wonder if that overcomplicates things a little bit. But there's no question it is an engineered solution to get to your suture material. And yes, the death switch on some models of anaesthetic machines. And that's why procurement is so important, that, you know, we shouldn't be encouraging manufacturers of these kinds of anaesthetic machines by buying them. It's a bit like bright pink house paint. Shouldn't be made. Right, Matt.
The when they changed the adapter on the end of NG tubes, that was the other another big one, wasn't it? I remember when that wasn't there. That must be reasonably recent. I'm not that old.
Yes. No, you're not. I'll come on to that in a minute. Actually, I've got a slide on that. Here's another bit of engineering. And it's topical given the Royal College's recent information about CO2 trace and esophageal intubation. This is not one of our machines, but we've got a capnography trace on one screen, and the airway pressure for the ventilator is on another screen. And so actually two pieces of information relating to the patency and the flow loop of gas that you've got are in very different places on a monitor. So you've got to work extra hard. The design is not making it easy for you to join up the information. Medical gas supplies, classic example of good design. This picture on the top right highlights some bad design. Does my pointer point? Is there a pointer? No, okay, yeah. How about that?
That works.
I don't know how to get rid of it now, but anyway. Oh, hang on. Cursor. How about now? Can you see a cursor? No. Oh, well, never mind. Air next to oxygen. So, I don't know, we had about 3 never events in our brand new ED department that put air next to oxygen and had rotameters plugged in, so patients being brought in by ambulance crews were being connected to air, not oxygen, not just in UHL, but all over the country. You know, it's a bit silly designing something like that. And why would you need air with the same kind of connector as oxygen anyway? For nebulizers, presumably, when you don't want to give oxygen at the same time. But again, seems a bit silly. But this is what happens in the 21st century still. So thinking about connections are really, really important. And here we are, the NFIT, as you say, Matt, and the NRFIT, which someone else has also mentioned. And Catherine's just also added suction and pneumothorax. So yeah, particularly when these things were infrequently used on wards, there can be an absolute hazard. When we're talking about design, actually this is particularly topical right now in terms of building for the future at Leicester Royal Infirmary and Glenfield with the new intensive care units. You don't want to make the mistake that Norfolk and Norwich made when they built their PFI hospital and forgot to build a pathology department in it. We've all heard of stories of hospitals built without elevators at all, or with, that was in New Zealand actually, a two-storey day case unit had to have a retrofitted ramp on the outside of the building so that they could get people out of the operating theatre from the first floor. But there is there's always an elevator in a hospital somewhere that isn't big enough for an orthopaedic traction bed, and that's why, as a form of checklist, actually the health building notes have been produced to try and, again, as a checklist, to try and make sure people don't forget to include the oxygen piping or a sluice or other things that, if you're on the building organising committee and you don't ever need to use the sluice or the storage cupboard for the fluids, you might not think about including that in the design. So the third thing in this particular incident that I wanted to just draw out as a particular theme was that whole point of why what we do in teams and why we train. We're not born fully formed as a competent anaesthetist. We can't necessarily do everything in every environment, and we certainly can't do everything on our own. And one of the big elements of this incident included someone not being a good host, not understanding what it was like to come into an unusual environment and be asked to do something that they weren't used to doing. Similarly, be a good guest. Don't offer to do something that you can't. So, don't offer to play the piano for after dinner singing if you can't play the piano. It feels ridiculous to even comment that being polite and kind to each other is an intrinsic part of patient safety. But we still probably all can recall incidents where it hasn't been as it should be. And have a look at the website and the videos on Civility Safe's website. It's good food for thought. I'm conscious of time and can quite easily talk for, I've got a couple more slides. Are we all right for time? Yeah. So this one is another thing that I want to emphasize, particularly about environment. Patient on ICU, needed an NGT for feed. The chest x-ray was done on a mobile x-ray, and the usual pre-feed checks were not completed. So unfortunately, the patient received feed and medication into their lung. Now, we could also, how could you miss that? Actually, the picture on the mobile x-ray is pretty good. There we go. We've got a line going down here. Looks like it's just about under the diaphragm. Absolutely perfect. And if you were in a hurry, because something's gone wrong, everyone's seeing the bright dot down the outside. You might have thought this was the external part of the nasogastric tube, if you didn't see that bit, because actually it's very easy for your brain to interpret what you're expecting to see. So for that reason, I'm now going to show you a picture of a rabbit. Can everyone see the rabbit? Can anyone not see the rabbit?
Actually, I saw it a duck, not a rabbit.
You thought it was a duck. So whenever I've put up, it's a duck. Yeah. So I've shown this to a room full of 300 people, and approximately half see a duck and half see a rabbit. And not everyone can see both.
Does it mean anything in person?
And everybody in the room is looking at exactly the same thing. My son would call that a sea eagle.
Okay.
Oh, okay, yeah.
Right, okay. He saw a seagull in the street and he called it a sea eagle, which I thought was brilliant.
Cool.
It does look a bit like a seagull.
A seagull. Love it. Sea eagle. Okay, but that is why there's a checklist for the nasogastric tube, because in fact, nearly 10% of all never events are malposition of nasogastric tube, and the adverse complications of this can kill patients. Of those never events, you know, well over 2/3 is misinterpretation of the chest X-ray because of that confirmation bias. You see what you're looking for and expecting to see, and the minute you see a line going under the diaphragm, you are persuaded that this is in the right place. Now, this is a change analysis grid. What should have happened? What did happen? And then the care that could have been changed. I won't go into the detail of it, but I found it quite interesting that this whole change grid didn't really take into fact that this was in May 2020, the beginning of our first COVID surge, and we had 29 level 3 patients at LRI ICU, designed for 18 is your usual max, I think? 17? 19. Okay. So yeah, it was really, really, so that context I think is really important. And I was just wondering if people feel comfortable to do so, to just, you know, what was it like in those first few weeks working in that environment? On the last incident, we talked about the distractions of an unstable patient and lots of monitors. And PPE as a sort of inconvenience these days. But thinking back to that time at the beginning, what was the working environment and how is it contributing to things not going as planned?
Mildly stressful.
Yep.
There were lots of patient factors because we didn't really know how to treat it, and we were treating ARDS type stuff and drying people out, which didn't really work. But there were lots of people on filters, so the nurses had loads of stuff to distract them. Yeah.
Yeah, and that's why some of the nasogastric aspirate before being used and all that sort of thing just didn't happen, because everybody was overloaded.
We had really sick patients in Bay C, which we wouldn't normally do, which is where this happened.
Yep.
So that's usually the quieter bit, and there's not much stuff and space and computers and all of that kind of thing.
And there's also no computer with an X-ray box, so there wasn't the opportunity to review the X-ray in the format that one would normally do. And so that was considered also a contributing factor, but to leave a busy environment, de-gown, go and look at the X-ray, come back, re-gown, that length of time was risk assessed by the individual concerned quite reasonably, I think, that they were able to see on the monitor that they had on the X-ray. And it's a combination of multiple factors, because it wasn't just one error that created the conditions in which this occurred. So yeah, PPE, cognitive overload. Jenny's typing some more things. PPE, improvised, no anti-fog kit, no X-ray viewing screens or functional computers in that area. Lots of redeployed staff who were unfamiliar with ICU. So I think that the really interesting point about that time too is that it was a foreign environment for lots of the intensive care people as well, wasn't it? So the redeployed people had brains that did not have much spare capacity to come into anything. 3 areas with ICU patients, consultants rounding multiple patients in multiple areas, and many more patients, and then phones difficult to use. So all that communication, and as you say, radiographers, I think not just the radiographers, Jenny, I think everybody was frightened at the beginning because we didn't know that our PPE was going to keep us safe. And now, thank God, we've got vaccines as well. That level of fear and the distraction that created for all of us is something that you know, it's really important not to discount that as a factor. And yeah, really good idea to try and limit each person's time in the hot zone for exactly that reason, this idea of cognitive overload, where you can only cope with so many things in your working memory at a time. And the more distractions that you have, the more difficult it is to retain information in your working memory and also to process and make decisions at the same time. And so the types of interference that we were seeing, particularly at that time of COVID, is, you know, all the stuff you see on a bad day, any day. Yeah. And Jenny's just added another massive change was the number of deaths that you guys were seeing on the intensive care unit relative to the normal throughput, which was, you know, you'd have your quota of short stay surgical patients who you were seeing helping get through major surgery and going on to actually having the opportunity to recover from cancer and from various other situations. And the psychological shift of that to a sense that in spite of what you had been trained to do, you weren't necessarily able to make a difference or understand why. And I can't imagine how difficult that must have been for people. Just to finish, a couple of comments about how do we mitigate the risk when we're in a stressful environment that's also unfamiliar. Zoe?
Don't rush. Take time to work it out, whatever it might be. You're not going to make it better by rushing in and trying to fix everything and shouting and waving your arms about and stuff. It never works. Yeah. Stay calm, basically.
It's also about that shortcut picture right at the very beginning. You know, don't take shortcuts. Fran's adding allocate tasks and delegate. Absolutely. Recruit other people's green box. That is the point of the team, isn't it? Matt, you go out and scoop up ECMO patients. How do you manage working? You're in other hospitals, theatres, you're with presumably a fairly core team of people on the retrievals. How do you cope with that environment, or does ice run through your veins and you don't need to worry about it? Sorry, for younger people on the call, I was Matt's educational supervisor, so
for them being bullied.
I'm asking for your professional input on this teaching opportunity.
You could have asked Vaz, he's on the call as well. No, I mean, it is strange actually, and I think I was, well, I haven't been out for a little while now, but I think it's weird going into that environment, in that theatre environment, as an anaesthetist and acting as a surgeon, because it feels quite alien, and having a sort of very different approach to that, to the theatre environment. But I think you just have to communicate very clearly with people. I mean, we try to send out documentation to the referring centres beforehand, so they already have an idea about what to understand, and that sort of lays things out in terms of where people, even down to where people should be standing in terms of cannulation and that kind of thing. So I think that makes it easier for us when we get there, because it's not completely alien to people. But you're right, because a lot of people that we might end up cannulating with in theatre may have never seen it before, or they might have done one in the last X number of years. So it can be a bit odd. I remember, I can't remember where I went. I was with Chris Harvey and went to pick a patient up from somewhere, and it was right in the middle of COVID, and there was literally nothing in the theatre. We got in the theatre and there was no kit, there was nothing to scrub into, there wasn't a scalpel blade, there was nothing. And another experience, me and Hakeem went to pick a patient up from Sandwell, I think it was, and again we go into the theatre and we'd sent out what we wanted, and they sent so we needed a C-arm and all this kind of stuff. And when we got there, they sent a normal image screening thing for what you'd take a picture in ITU, and there was again no kit, nothing to scrub your hands with, no swab, nothing. So I think it's just being really clear in communication and appreciating that it's stressful for everyone else as well, and trying to stay cool, even if well, that's just being an anaesthetist, isn't it? It's like being a swan, graceful on above the water and flapping like underneath.
Jenny has put in the chat, I find voicing vulnerability and acknowledging that I'm out of my usual zone to those around me helps others keep me safe and empowers them to speak up if I'm missing something. I think that is a really quite profound observation, and I've also had the experience of at team brief in the morning explaining to my team that I'm off my game, there's been a family bereavement, I'm distracted, tired and sad. And I was really amazed at the response that I got from my team, keeping me safe, keeping, so if I do something stupid, please stop me. If I look like I'm distracted, speak to me and tap into me. And showing that vulnerability, particularly as senior clinical leaders in the workplace, is, I think, a really, really powerful way of teaching to all the members of the team, not just our own anaesthetic and intensive care trainees, that we're all human, we can all be having a bad day, and actually speaking up when you're not sure why Dr. Gross is doing that. It might be that Dr. Gross is drawing up the wrong drug in the syringe because she really shouldn't be doing two things at once. And Fran says, I recognise and really appreciate it when Jenny does this. So, go be role models out there yourselves and show your team how we should all be working all the time. So, a couple of ideas about mitigations. The reality is we work in a risky environment all the time, but we mitigate that risk. Our professional training, providing supervision, team working, communication, using protocols. Matt talks about sending out information of where to stand in theatre. Actually having a red line that says, if these conditions aren't met, I am not proceeding. That's part of your professional accountability, and it can be difficult to do if you're feeling relatively junior in your role or intimidated by other people around you. But that's why there's a consultant on call, or that's why if you are the consultant on call, you phone a friend, because backing each other up is all part of an important safety culture. So just to remind that actually, in fact, most of the mitigations are met if we are using not only our technical skills when we're in a strange environment, but that we're also putting into play the non-technical skills that we all do every day without even thinking about them or giving them a name. But They are utterly intrinsic to safe patient care. And that's all, and probably quite enough from me. Any questions or comments?
Thank you is a comment, I think. Thank you very much, actually, for that.
Thank you. You're welcome.
That's what I was going to say. Thanks, Jeanette.
Absolute pleasure.
I hope people will think about what they're doing and try and apply some of it rather than just rushing in.
My absolute, you know, I think the take-home message is Matt will start twitching if I talk about reflection too much, but we need to understand that this is who we are. We can't help ourselves. We will look to take shortcuts. So be aware of that and make sure that if you find yourself taking a shortcut, are you really safe to be doing this? Or are you at risk of ending up with egg on your face? See what I did there? I think that might be enough from me. Best wishes, everybody, and have a great weekend.
So first of all, again, let's repeat that it's a bit out of my comfort zone. I usually, when I look to a paper, I just look to the conclusion. I don't go more in depth in any paper. And it was one of the rarest time that I concentrated too much to understand actually even the paper and what does it say. So very quickly as a start, the trial which I am sharing with you now is vasopressin and methylprednisolone for intra-hospital cardiac arrest versus a placebo trial. And it was done in 2020 till the 2021, January 2021. It was a year, and it was in Canada, in 10 hospitals. So it was a multi-center one. So the first thing is, their previous trials have suggested that the vasopressin and methylprednisolone administered during in-hospital cardiac arrest might improve outcomes. And actually, this was two trials done by Zilopoulos in 2009-2013. I was quite thinking when I was reading this study why they repeated it, and then they discussed by the end that there are several factors for that number. First, one of it was the number of the involved patients in the trials were low. So it said that in the trial in 2009 there were 100 patients, while in 2013 was 268. So collectively they were both like 368. Simply this trial, the old trials, compared the addition of vasopressin, 20 injection unit with each dose of epinephrine, and 1 dose of glucocorticoids, 40 milligrams of methylprednisolone during the cardiac arrest versus a placebo with a normal saline. This time, the main objective, again, was to determine whether really the combination of vasopressin and methylprednisolone administered during in-hospital cardiac arrest improves ROSC. Because despite the current guideline, despite the previous trial, the current guidelines in USA and European guideline doesn't recommend, still reflecting lack of clinical trials data that confirmed the findings in this study, in the previous study. I will go a bit again in the previous study. So the results were that the most recent and largest of them, which was in 2013, with a total number of patients, I say 268, found that the survival with favorable neurological outcome occurred in 18 out of 130 patients, with about 14% in the intervention group, compared to 7 out of 138, 5% in the placebo group, which was statistically significant. This again, this trial was investigator-initiated, and I stopped at this point because I don't know what the meaning of an investigator-initiated. So I googled it up, and it came out as that it was a trial that initiated like in an institution or something like that, that they are the one who initiate the trials rather than being clinically initiated. And it's a multi-center and randomized placebo-controlled double-blind trial. Regarding the patients, 10 hospitals in Denmark, and actually there was 4 university hospitals of them. Inclusion criteria was that it need to be an in-hospital cardiac arrest, at least receive 1 dose of epinephrine, and let's go quickly to this, to the inclusion criteria. And so here it say that the trial had at the start 2,362 patients, and the excluded are 1,850. 685 didn't meet the inclusion criteria, as there's 662 didn't receive the epinephrine, and 23 aged below 18. So also this was one of the inclusion criteria, being age more than 18. And the exclusion criteria were that if they ask for do not resuscitate, so this is an exclusion criteria. If they have prior enrollment in that trial before, again, to be excluded. If mechanical circuit support like an ECMO was on them, to be excluded. And if pregnancy, to be excluded. And then there was other reasons for exclusion happened. One of them, for example, was like physician decision, which was happened during the arrest. And this, again, one of the differences between this trial and the previous trial. The previous trial, the one who was injecting the drugs was a different person rather than the physician leading the CPR. This time, it was the physician who's leading the CPR was the one who is giving the medication. And they say that early termination of resuscitation, clinical team forget to do it, or return of ROSC prior to giving the drug. These are also part of the exclusion of criteria of the patients. Sorry. Let's go back. Randomization. So here, as it appears, so 512 were randomized. It was 1-to-1 number control, so 1, 3, 5, 7 like that, and 2, 4, 6, 8 even and odd numbers. And 245 received the trial drugs, and 267 received the placebo. So the design, the intervention said that we are going to give 20 units of vasopressin after the first dose of epinephrine, and with each dose of epinephrine with a maximum of 4 doses. And once methylprednisolone 40 milligram once IV infusion. And then the outcomes. So here also they said the primary, secondary, so I didn't write this one properly, and there's also a tertiary outcome. Starting with the primary outcome was the ROSC, how many patients return of spontaneous circulation, and then secondary outcome was again, survival for 30 days with favorable neurological outcome using a score which is called Cerebral Performance Category Score Scale. And the tertiary was including other scores like the Modified Rankin Scale for adults and children, and also another one, a European. It's have very hard numbers like European score, EQ5D, something like that. It is European score, which is this one I'm going to explain a little bit later. Looking to the score, sorry for that. Regarding the cerebral performance category score, is scaled from 1 to 5, being 1 and 2 good favorable outcome, 3, 4, 5 are bad outcomes. For the modified ranking scales, it says on the right side, you can see it like no symptoms at all give 0, and 6 is dead. So whenever number increased, the score is the worst. Same going for the other scoring questionnaire, which scores mobility and self-care and like that. And the larger the number is, the worse the mental state. Results. So starting with the primary outcome, it stated that 100 of the 237 returned ROSC in the vasopressin and methylprednisolone group, which is about and 42%, and 86 out of 264 in the placebo group, which is about 33%, with a percentage difference of a 9.6, which is statistically significant. The problem happened when they did the secondary outcomes to see the 30 days and the 90 days with different scores. So if we looked here at the survival after 30 days, it's 23 out of the 100 which survived in the first in the vasopressin and methylprednisolone, while 31 out of the 86 from the placebo ones, with a difference of a -2%. Again, scoring for favorable neurological outcome with the cerebral performance category, the first one, was 18 in the vasopressin and methylprednisolone, and it was 20 in the placebo group. Again, regarding the favorable outcome, when they used the other scores, it was quietly switched, and here it was 11 only in the vasopressin, methylprednisolone, and in the placebo 90. I'm not going to bother you too much with the numbers, but what we can get here from the results is that the primary outcome as return of ROSC, again, it was statistically significant, and it will be again stated in the conclusion that really vasopressin and corticosteroids does look to help in returning of circulation. But ongoing with the secondary outcomes, as we can see, we are not sure if it can improve the neurological outcome, or it might worsen or harm as the neurological outcome on the long time. Very quickly, again, the difference between both trials: number of patients who administered the trial drugs, and in the first trial, the old one, they also give steroids post-resuscitation for the patients who had sepsis or had hypotension after the operation, after the returning of ROSC. The conclusion is, among patients with in-hospital cardiac arrest, administration of vasopressin and methylprednisolone compared with the placebo significantly increased the likelihood of return of spontaneous circulation. However, uncertainty whether this treatment results in benefit or harm for long-term survival. I'm not the person to say again if you have any question, because I myself still have more questions actually in this patient, in this study. One of them actually, if we reach that point, would we use them or not? Why they are not being used? Still, we have a previous slide say that they are significantly it can return ROSC, and at the same time they are neurologically favorable. This one is uncertain about it, but there's still some sort of numbers that state that it might be neurologically favorable. If anyone can help actually in answering or giving me a guide about it, I'll be very happy. Anyone hearing me actually?
Yeah, we can hear you, Bas.
Okay.
Can you just stop sharing your screen?
Stop. I stopped.
Okay, so what do people think? What would you do about it?
Okay, I'm not in a position to, how can I say, to introduce new things without being confident of at the moment. And still I'm on a register, so I would stick to the guidelines. But if you're asking me, I won't think that it won't be a bad idea. I think it needs a go. It needs a better trial and better move. There's drugs we are used usually for other reasons during the very profound ill patient using a vasopressin or using the corticosteroids. And I don't have any confidence in seeing the number that they really do harm. on the other hand, they really helped in returning of spontaneous circulation. So I think it's worth to have a more generalized trial.
What do people think about the primary outcome measure? Not just Abbas, anyone else who's listening. Do you think it's the right thing? Is it the correct thing to measure?
No.
Nobody's got any thoughts.
No, it's not the best thing to measure. That's what I can say. Even what I can see, we were not just want him to return of spontaneous circulation. We want improvement in the neurological functions.
Yeah, Heather, you got your hand up.
Yeah, really?
Yeah, I was just going to say the same thing. I think ROSC. Obviously, you're not going to get neurologically meaningful outcome if you haven't got ROSC, but I think, as with most of these trials where you try something new, you see an increase in ROSC rates, but very rarely, if ever, have they actually helped with meaningful neurological outcomes. Probably because the people who are going to have neurologically meaningful outcomes have an easier ROSC anyway. This is what we've seen on multiple trials for multiple different agents to try and improve ROSC. And I think the secondary and tertiary outcomes are far more important than the ROSC as the primary.
Yeah, that's kind of the point that I was getting at as well. I think that as a patient, the meaningful outcome is survival. Survival is important, isn't it? But actually, it's sort of if you want to survive, then you want to survive to a point where you're going to be able to be aware of it. And I think that's slightly the issue. It's maybe not that patient focused in terms of an outcome. Because granted, with vasopressin and methylpred, you seem to get a higher number of patients getting ROSC, but you also get a smaller percentage of those patients go on to survive at 30 to 90 days, and with a poorer neurological outcome. So I don't know. I suppose there's no signal for harm, I suppose, there, because ROSC is a positive, so you can't argue not to give it. But is it a game changer? It doesn't feel like it. Don't know if anyone else has got any opinions.
I'm just also one thing I'm thinking of why it might harm. Why?
Well, I'll come in again. I mean, I think the potential is for harm. If a patient does survive, but they have significant neurological deficit, that's potentially more harmful both to them and their loved ones than if they didn't have ROSC and didn't have that neurological outcome. So I think there is a potential for harm. It's that's getting into some very difficult ethical waters, I know.
Yeah.
But I don't think you can say just because somebody survived, no harm has been caused either.
No, and actually, I think a lot of people would probably agree with your comment there, Heather. I think personally, if I was surviving, I'd want to survive to the point where I'd be aware of it and be able to have a reasonable quality of life. But not everyone thinks the same way that we do. And actually, being alive full stop may be a positive for some people and their families, more importantly, than the opposite.
Yeah, so you can assume anybody's views.
It's like Jenny says there fate's worse than death. I think that's probably very true. And we think like that, but that doesn't mean that everyone thinks the same way. And you're right, it does get into some ethically murky water. Anything else, Abbas? I like how you quite openly admitted that you always go straight to the conclusion. That's it's an interesting way of analysing evidence.
It's the first time I read it. I tried to unsend all the numbers, and it was quite really hard. Actually, I did it on 3 days just to try to say how I'm going to say it, because it's everything contradicts each other. So all the numbers are quite opposite to each other. So he's doing a trial, which the number is not consistent with. I till now I don't know why he said by the end we are not sure with it benefit or harm, because the number of the neurological outcomes were pushing toward the point of harm like that. It's only one of the scores which say that it benefits. But again, when I'm looking to the score itself, so the one with the questionnaire, it looks actually like it says like sometimes it's done at home or something like this, and it's very, very objective or subjective, I can say. Or maybe someone who feel that he can't walk properly, for example, this is a very bad outcome. Not quite sure. Yeah. It's just like it maybe also my culture and background affects even my opinion, especially at this point, whether it's good to return or not to return, which are my basic conflict here since I came in.
No, I get that. Yeah, I think so. If nothing else, I think this is sort of it's a useful task to point out that you've got to bear in mind that whenever you read a paper, even if you just read the abstract, the authors are trying to catch your attention with that and to make you read it, and the journals who publish them want that to try and pique your interest. But what you need to do is actually read the full paper and try and understand a little bit about what's actually happened, and not just the highlights that they've put on the abstract, because obviously the truth might not be the same as what you're reading right in that little snippet. So yeah, good learning point there, Abbas. Well made.
Yeah.
Okay, anyone got any other comments on the paper or anything they'd like to ask?
Matt?
Yeah.
I was just thinking, how difficult or easy is it to get vasopressin and methylprednisolone when you're running for a cardiac arrest?
Well, you tell me.
I don't think I can get it that easily.
Yeah, I think it's a good point, isn't it? So obviously in this setting, you would expect, or you would hope that this was set up in a way that actually was sort of a grab bag type scenario where the stuff to be administered was there, and it was either a placebo or the drugs, and that was the way it was set up. And it's like anything, isn't it? If you're going to implement these changes, you need to have some sort of system changes so it becomes easier. It was sort of like when we used to use cold saline for cardiac arrest. If you tried to do that now, it would almost be impossible because you wouldn't know where to find it, etc., and it would take too long. Whereas when we were doing that, it was there. Everyone knew where it was. It was well stocked. You knew you just grabbed it. And this is sort of a similar scenario, isn't it? Because we don't do it now, it would be almost impossible to implement it. So yeah, you're right. You couldn't do that now, but I think if it was something that ended up having a good evidence base, like anything, you'd change the system in order to make it happen.
Yeah, exactly. Like amiodarone, for example, it wasn't before, and then it entered the protocol. So it's now available in a special syringe for that. It will be the same if it's of use. Yeah.
Well, obviously, methylpred, there was national shortage of that, so that will probably stop using that. Cool. Any other points or comments? No? Okay, thanks for that, Abbas. That was great.